Okay, Dr. Rabatakala, kindly please proceed with the question. First read the lead question. Yeah.
Which of the following is the most likely cause of his symptoms? Monoclonal gammopathy of unknown significance, chronic lymphocytic leukemia, parvovirus B19 infection, Waldenstrom's macroglobulinemia, visceral leishmaniasis. As a 70-year-old man presents to the hematology clinic with lethargy, weight loss, and night sweats over the past 3 months. He is particularly concerned as over the past month he has begun suffering from headache and blurred vision and has suffered some bleeding around his gums when he cleans his teeth. He has hypertension but otherwise well. His blood pressure is 152 over 90 millimeter mercury and his pulse 85 beats per minute and regular. You note a purpuric rash affecting both the upper and lower limbs. His abdomen is soft and non-tender with no mass, I think. With no okay. Investigation hemoglobin is normal. White BCs within the normal range. Platelet also within the normal range. Sodium within the normal range. Potassium normal. Creatinine is a bit high, 132. Calcium within the normal range as well, 2.3, the upper limit. Yeah. Platelet electrophoresis, immunoglobulin IgM, paraprotein pan, 32 gram per liter. Which of the following is the most likely cause of his symptoms? Monoclonal gammopathy of unknown significance, chronic lymphocytic leukemia, parvovirus B19 infection, Waldenstrom's macroglobulinemia, visceral leishmaniasis.
Okay, so the plasma electrophoresis is showing the immunoglobulin paraprotein band, and the amount is 32 gram per liter. And we know that the IgM paraprotein band, this is associated with two conditions. One is the Waldenström macroglobulinemia, and second one is the MGUS, monoclonal gammopathy of the unknown significance. So how will we differentiate between WM and MGUS? In case of WM, the IgM paraprotein level should be greater than 30, and there should be evidence of end organ damage. And in case of MGUS, the IgM paraprotein level should be less than 30, and there will be no end organ damage. And also in case of WM, there will be features of hyperviscosity. So if we look at here, the IgM paraprotein level is greater than 30. The creatinine level is mildly elevated here, indicating the end organ damage. And let's look for the features of hyperviscosity. So the patient is having the headache, blurring of the vision, hypertension. All of them are the features of hyperviscosity. So features of hyperviscosity plus end organ damage plus IgM paraprotein level greater than 30. The diagnosis is the WM, Waldenström macroglobulinemia. Yeah, so Waldenström macroglobulinemia is a B-cell lymphoproliferative disorder which leads to the production of IgM paraprotein band. This is associated with the hyperviscosity and the headache, blurring of vision, hypertension, features of stroke. All of them are the features of hyperviscosity, and the treatment should be rituximab-based chemotherapy regimen, or you can also go for plasma exchange. And in case of MGUS, there will be no end organ damage, but there will be end organ damage in case of WM. Paraprotein band should be less than 30 in case of MGUS. It should be greater than 30 in case of WM. And the plasma cell within the bone marrow should be less than 10 in case of MGUS. So greater than 30 plus end organ damage indicates WM. Less than 30 plus no evidence of end organ damage, this indicates the MGUS.
Great. Yeah.
Okay, next one, please.
Which of the following is most useful investigation to confirm the diagnosis? Monospot testing, serum cytomegalo immunoglobulin M, IgM, serum measles immunoglobulin, IgG, oral fluid measles, IgM, oral fluid measles ribonucleic acid, RNA. So a 22-year-old student comes to the emergency department with an erythematous multiform rash, which began on her forehead and then spread to involve the neck, trunk, and upper limbs over the past 36 hours. She also has lymphadenopathy, conjunctivitis, and pharyngitis. She tells you that she has not received the mumps, measles, and rubella vaccination. Her temperature is 39.3 degrees centigrade and pulse 98 beats per minute and regular. There is a quiet wheeze on auscultation of the chest. Investigation, hemoglobin within the normal range, white PC is also normal, platelet is normal, sodium within the normal range, and potassium and creatinine all within the normal range. CRB is elevated, 58. Which of the following is most useful investigation to confirm the diagnosis? Monospot testing, cytomegalovirus immunoglobulin, IgM, serum measles, IgG, oral fluid measles, IgM, oral fluid measles, RNA.
Okay, so this is a case of this is basically a hello, can you hear me?
Yes, for me, I
Okay,
hear.
okay.
Yes, sir.
So basically, this is a case of there is a erythematous morbilliform rash, and the patient has come up after the 36 hours. So the most likely diagnosis here is the measles. And if we look at the options here, among the 5 options, the monospot testing, this is the screening test for the Epstein-Barr virus, CMV immunoglobulin IgM. This is done for the CMV infection. So these two are out of the equation, and the serum measles immunoglobulin G or IgG, IgM, and oral fluid measles RNA. All the three can be utilized in the diagnosis of the measles. And for this, we will have to look at the we will have to look at the duration.
Mm-hmm. Yeah.
So in case of oral fluid measles RNA, it should be positive from the time of appearance of the rash up to 3 days. So from the time of appearance of the rash up to 3 days, the oral fluid measles RNA, this would be positive. This would be the first to become positive. And after that, we know that IgM indicates the acute condition, or you can also remember as macute or acute. Oral fluid measles IgM, this will appear in the acute condition, and this usually appears after 3 days of appearance of the rash. So the oral fluid measles RNA, this is coming along with the rash up to 3 days. This will be positive after 3 days, and this will remain elevated up to 7 days. And the IgG indicates chronic, and G and C almost look like similar. So remember IgG, this indicates subacute or chronic. And serum measles immunoglobulin IgG, this will become positive after 1 to 2 weeks. So oral fluid measles RNA will be positive from the time of appearance of the rash. It will remain elevated up to 3 days. IgM will be elevated after 3 days. IgG will be positive after 1 to 2 weeks. So now let's get back to our question here. Here the duration of appearance of the rash is only 36 hours. That means within 3 days. So we should go with the oral fluid measles RNA. In the early measles, detection of measles virus RNA in the oral fluid is the investigation of choice. It is detected by reverse transcriptase polymerase chain reaction and remains positive up to 3 days after the appearance of the rash. So from the appearance of the rash up to 3 days, oral fluid measles RNA, this should be positive. And the IgG means chronic, so it will be positive after 1 to 2 weeks. And the IgM indicates acute, it will be positive up to 3 days. So just by looking at the duration of appearance of the rash, we'll go with the testing. Okay.
Okay. Which of the following is most likely diagnosis? Agoraphobia, anaca, anaca, sorry, anachronistic personality disorder, bipolar disorder, yeah, bipolar disorder, borderline personality disorder, obsessive compulsive disorder. The question, please. A 38-year-old woman comes to the psychiatric clinic for review. She's concerned that a need to wash her hands many times a day and avoiding public toilets is impacting significantly on her life. At home, she must wash her hands up to 12 times. After each occasion, she visits the toilet and she cannot touch public toilets, such that she completely avoids going out whenever possible so that she can avoid public toilets completely. She feels these problems began after a bout of gastroenteritis some 3 years earlier. Which of the following is most likely diagnosis? Agoraphobia, anachronistic personality disorder, bipolar disorder, borderline personality disorder, obsessive compulsive disorder.
So washing our hands up to 12 times a day, this indicates the OCD, obsessive compulsive disorder. So how will you treat this patient or manage this patient?
Is it psychotherapy or?
Yes, very good.
Psychotherapy, okay.
OCD, the obsessive compulsive disorder. The first line treatment should be the CBT, cognitive behavioral therapy, and you can just remember the shortcut for all psychiatric disease except schizophrenia. The first line treatment should always be the cognitive behavioral therapy, except schizophrenia. Okay.
Which is the most likely diagnosis? Compensated metabolic acidosis, compensated respiratory acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. A 28-year-old woman who has asthma comes to the emergency department having collapsed because of shortness of breath at a local nightclub. On arrival in emergency department, she is complaining of pins and needles in both hands. Her blood pressure is 105/80 millimeter mercury and pulse 95 beats per minute and regular, and her respiratory rate is 37 beats per minute. Investigation, pH high, 7.9, oxygen saturation, oxygen 14.2, yeah, CO2 3.2, low, and bicarb is a lower limit 22 millimolar per liter. Which of the following is most likely diagnosis? Compensated metabolic acidosis, compensated respiratory acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis.
So this is about the ABG interpretation. Can anyone tell me the diagnosis here from the ABG parameter?
Respiratory alkalosis.
Yes,
Respiratory alkalosis.
Respiratory alkalosis.
This is a case of respiratory alkalosis, and the original concept for the detection of the ABG interpretation is very difficult, and I am just teaching you one of the shortcut method. This shortcut method is just applicable for MRCP part 1 exam. This is not the real explanation. So the first step would be to detect whether this is a case of acidosis or alkalosis by looking at the pH. If the pH is less than 7.35, then this is acidosis. If the level is greater than 7.45, this is alkalosis. And the second step would be we will correlate the partial pressure of carbon dioxide and bicarbonate with the pH. If they are directly proportional, this indicates metabolic. If they are inversely proportional, this indicates respiratory. So pH here is greater than 7.45. So this is alkalosis. Now we'll have to correlate partial pressure of carbon dioxide and bicarbonate with the pH. So pH is high here, but the partial pressure of carbon dioxide is low here. So this is inversely proportional, and inversely proportional means respiratory. And again, bicarbonate is low here, but the pH is high here. This is also inversely proportional. So inversely proportional again means respiratory. So from the pH we are getting, this is alkalosis. From the inverse relation we are getting the respiratory. So this is a case of respiratory alkalosis. Okay, next one.
Which of the following is most appropriate way to manage this patient's hypercalcemia? Cinacalcid, increased oral fluids, intravenous epandronate, oral raloxifene, prednisolone. A 49-year-old man presents to the clinic for review. He has shortness of breath and increasing tiredness with a persistent test over the past 4 months. His dry cough has not improved despite prescription of salbutamol inhaler by his GP. You note an erythematous popular rash on the face, particularly around the nose, and erythema nodosum on both chins. His blood pressure is 145/82 mmHg, and his pulse is 78 beats per minute and regular. There is no wheeze on auscultation of the chest. His abdomen is soft and non-tender. His body mass index is 23 kg per square meter. Investigation: hemoglobin and white disease and platelet all within the normal range. Platelet also sodium, potassium, creatinine within the normal. Calcium is a bit elevated. Bicarbonate 25 millimolar per liter within the normal as well. Which of the following is most appropriate way to manage this patient's hypercalcemia? Cinacalcid, increased oral fluids, intravenous epandronate, oral raloxifene, prednisolone.
So this patient is having the dry cough, and along with the erythematous papular rash, and there is also erythema nodosum, and the lab parameters is showing the hypercalcemia. So hypercalcemia plus dry cough plus erythema nodosum or the Sheen lesion. So the most likely diagnosis is the
Sarcoidosis.
yes, exactly.
Sarcoidosis.
The most likely diagnosis is the sarcoidosis, and the increasing tiredness and persistent thirst. These two are the features of symptomatic hypercalcemia. Yes, very good. Symptomatic hypercalcemia. And we know that in case of sarcoidosis, if the hypercalcemia is asymptomatic, then we don't need to treat the patient. But if the patient has the symptomatic hypercalcemia, then we'll have to treat the patient. And just we can remember with the help of C for calcemia or hypercalcemia, C for symptomatic, and C for corticosteroid. The default choice of treatment or the first line treatment in a patient with sarcoidosis coming up with the symptomatic hypercalcemia, we'll have to treat with the corticosteroid. This should be the first line treatment. And if the patient doesn't respond to the corticosteroid or the prednisolone, then we'll have to use the steroid sparing agent, and among the steroid sparing agent, azathioprine should be preferred. So the first line treatment is the corticosteroid or the prednisolone. So corticosteroid, this patient has hypercalcemia in patient with sarcoidosis, so treat with the corticosteroid. And if the patient doesn't respond to the steroid, then use the steroid sparing agent, meaning the azathioprine.
Which of the following is most appropriate intervention? Beta blocker, calcium channel antagonist, flecainide, implantable cardioverter defibrillator, reassurance. Scenario, please. An 18-year-old man is referred to the cardiology clinic. He received an ECG as a part of a signing in progress as professional footballer, and QT interval of 490 milliseconds was noted. On further questioning, he tells you that his grandfather died suddenly at the age of 29. His blood pressure is 118 over 80 millimeter mercury, and his pulse 74 beats per minute, and regular physical examination is unremarkable. Routine blood tests are normal. Which of the following is most appropriate intervention? Beta blocker, calcium channel blocker, flecainide, implantable calcium defibrillator, reassurance. Calcium channel antagonist. No. Flecainide, implantable defibrillator, or reassurance.
So the patient is having the QT interval of 490, and when the QT interval is greater than 450, then the most likely diagnosis is the long QT syndrome. And in case of long QT syndrome, if the patient has a if the patient is of low risk case, the low risk case means the patient has never been in any arrhythmic in any arrhythmic event, or any cardiac arrest event. This indicates the low risk case, and the low risk long QT syndrome is treated with the beta blocker. And if the patient has any history of arrhythmia event, or the patient has a history of significant ventricular tachycardia or cardiac arrest, then this indicates the high risk cases, and high risk patient with long QT syndrome should be treated with the ICD, implantable cardioverter defibrillator. So for low risk patient, treatment should be given with the beta blocker. For high risk patient, treatment should be given with the ICD. And if the patient can't tolerate beta blocker, then we can go with the stellate ganglionectomy. So long QT syndrome, QT interval greater than 450. This is the low risk case, so we'll have to treat with the beta blocker first.
To which of the following foods is most
Excuse me,
likely?
sir. How to know that it's a low risk case and or a high risk case? Can you elaborate on that?
Okay. So for high risk case, there should be any arrhythmic event. The patient will have the history of arrhythmic events, and also the patient might have the features of ventricular tachycardia or ventricular arrest or cardiac arrest. These features will be present either arrhythmic event or ventricular tachycardia or ventricular arrest or cardiac arrest. All those features should be present in case of high risk cases. And in case of low risk cases, no such features would be present, and the patient will be simply almost asymptomatic. There will be only mild symptoms, just either palpitation or just of the tiredness, nothing else.
But he has a strong family history. Doesn't that make it high risk?
No. The strong family history doesn't make that high risk. The symptomatology of the patient, the anti-arrhythmic event, or the susceptibility to the cardiac arrest event, this indicates the high risk cases, not the family history. Okay, next one.
To which of the following food is most likely to be allergic? Apple, banana, broccoli, cucumber, sorry.
Yeah, it's the
E, please.
cucumber.
Yeah. Watermelon. A 20-year-old student comes to allergy clinic for review. He complains that on eating certain foods, he suffers from an itching sensation affecting the inside of his mouth. He has paid for allergy testing from a private general GB, which has revealed an allergy to perch pollen. This is consistent with his symptoms when he gets high fever in spring. Which of the following foods is most likely to be allergic? Apple, banana, broccoli, cucumber, watermelon.
So this is the classical scenario of the oral allergy syndrome, and more specifically, this is the case of barge apple syndrome. And this usually occurs. The patient comes up with the hay fever in the spring, And this barge pollen allergy, this is associated with the eating of the apple. This is known as the barge apple syndrome, and we'll have to give the patient cooked apple. This patient,
This is sorry, the seeds of the. I think the seeds of the apple, not the apple per se, or the allergy, right?
the barge apple
Is it the,
syndrome, the general heading is the oral allergy syndrome, and within the oral allergy syndrome there are multiple subtypes. One of them is the barge apple syndrome. Okay,
okay?
this patient has the barge apple syndrome consistent with spring hay fever related to the barge pollen. Barge pollen allergy is most associated with food allergy to apples, but allergy is also seen in cherries, plum, apricots, and pears.
Mhm.
And banana is associated with the ragweed allergy. Broccoli allergy is most commonly seen in patients with mugwort allergy. Cucumber allergy is also with the ragweed. Cucumber and banana, both of them with the ragweed allergy. Watermelon is also the ragweed. So cucumber, watermelon, and the banana, all three are related to the ragweed allergy. Broccoli is with the mugwort allergy, and apple is with the barge apple syndrome.
Okay, great.
Okay, next one.
Which of the following is most likely case of his skin changes? Drug-induced photosensitivity, insect bites, nettle rash, photo, phyto, photodermatitis, sunburn. Uh, a 47-year-old landscape gardener comes to the emergency department with an erythematous blistering rash affecting both forearms. He says he was clearing a patch of waste ground, including clearing some giant weeds over the past day, and was wearing shorts and t-shirt due to hot weather. He has hypertension, for which he takes Prampril. Examination reveals erythema and blistering over both forearms. Although his face and lower limbs are tanned, it is it is his arms that are most affected by the rash. Which of the following most likely cause of his skin changes? Drug-induced photosensitivity, insect bites, nettle rash, phytophotodermatitis, sunburn.
So the here history of a gardener and clearing of the giant weeds, the occupational history has been given here, and the patient has come up with the blistering rash. Blistering rash has affected both his forearm, and there is also erythema and blistering over the both forearms. Facial region, lower limb are tense, and his arms are mostly affected by the rash. So just looking at the occupational history here with the gardener giant weed along with the blistering rash and also with the erythematous lesion. So the most likely diagnosis here should be the phytodermatitis. The sunburn can also come up with this type of picture, but in case of sunburn, the history of gardener or clearing the giant weeds won't be given. This will have the general history. So the most likely cause of skin changes here is the phytodermatitis, and this is associated with the some kinds of phytotoxic plants, and most probably the giant weed, some of the giant weed contain the phytotoxic plant here. The extensive erythema seen here with blistering confined to the forearm where the gardener may have been removing weeds is consistent with phytodermatitis. The rash begins within 24 hours after exposure and reaches its peak 48 to 72 hours later. The Carrot's family, including the hogweed species, is known to be responsible for phytodermatitis. Other causes include Rutaceae and Moraceae, the citrus and mulberry families. When the patient realizes they have come into contact with phytotoxic plant, they should wash the area with soap and water as soon as possible and avoid sun exposure to the area of skin for up to 3 days. So this phytotoxic plant along with the extensive erythema and blister confined to the forearm points towards phytodermatitis. And the prevention is washing the area thoroughly with soap and water and avoid the sun exposure for up to 3 days.
Okay. Which of the following is the strongest risk factor for development of AD? Family history of early onset disease, hypercholesterolemia, hypertension, smoking, type 2 diabetes.
So this is a direct question. We don't need to go through the scenario. So which one is the strongest risk factor for the development of Alzheimer's disease?
Family history.
Yes, family history of early onset. This is the strongest risk factor for the development of Alzheimer's disease. A family history of early onset Alzheimer's disease is the strongest risk factor for the development of the disease.
Sorry, what's AD disease? What's
AD means Alzheimer's disease. Alzheimer's. Okay.
Alzheimer. Okay. Alzheimer. Okay. Yeah. Alzheimer.
Who has recently been diagnosed with the Alzheimer's disease? So their AD was pointing towards Alzheimer's disease.
Yeah, that's fine.
Okay, next one.
The question, please. Which of the following is most appropriate mixed intervention? Azathioprine, ciprofloxacin, infliximab, naproxen, prednisolone. A 32-year-old man comes to the emergency department complaining of joint pains affecting his right knee, left and right ankles, and the toes of his right foot. He also has heel pain affecting his left heel. Of note is that he visited the pharmacy to buy some eye drops for conjunctivitis a few days earlier and had an episode of palpable Campylobacter gastroenteritis 2 to 3 weeks ago. You confirm the presence of arthritis affecting both lower limbs and psoriasis-like rash on the soles of both feet. Investigation: hemoglobin, white disease, and platelet all within the normal range. Sodium, potassium, and creatinine within the normal. CRP is elevated 82 milligram per liter. Which of the following most appropriate mixed intervention? Azathioprine, ciprofloxacin, infliximab, naproxen, prednisolone.
So this patient is having the features of arthritis, conjunctivitis, and we know that in case of reactive arthritis, we get the classical triad. What is the classical triad for reactive arthritis? Urethritis, arthritis, and conjunctivitis. Yeah. So conjunctivitis is present here and joint pain arthritis is present here, but they have mentioned regarding the conjunctivitis. And we also know that the reactive arthritis, usually they come up either after the exposure or they come up after the gastroenteritis. So they will either give the history of sexual exposure or history of gastroenteritis. And psoriasis like rash on the soles of both feet. This is known as keratoderma blennorrhagica. There are keratoderma blennorrhagica. This is also suggestive of the reactive arthritis. So arthritis, conjunctivitis coming after gastroenteritis with keratoderma blennorrhagica with elevated C-reactive protein. The most likely diagnosis here is the reactive arthritis, and the first line treatment for reactive arthritis is the mild to moderate potent oral NSAIDs. You can either go with the naproxen, and if the patient doesn't respond to the NSAIDs for second line, we can give the prednisolone, oral prednisolone. And if still the patient doesn't respond to oral prednisolone, then we can go with the intra-articular steroid. So naproxen or mild to moderate potent NSAID is the first line. Oral prednisolone is the second line, and third line is the intra-articular steroid. So conjunctivitis, oligoarthritis affecting the lower limbs, and keratoderma blennorrhagicum or psoriasis-like rash which affects the sole of the both feet. This picture fits with the reactive arthritis as a result of his recent episode of gastroenteritis. The NSAIDs are usually the first step of management, and you will have to give mild to moderate potent NSAIDs.
Yeah. Which of the following is most likely diagnosis? Functional illness, narcolepsy, obstructive sleep apnea, poor sleep hygiene, temporal lobe epilepsy. A 32-year-old man comes to the clinic complaining of excessive daytime sleepiness. His symptoms began after a head injury a few months earlier, sustained after a fall from a horse. He also reports hypnognostic hallucinations, episodes of sleep paralysis, and on a few occasions, at times of stress, he has suffered episodes of collapse and sudden muscular weakness. His blood pressure 1 to 1 over 81 millimeter mercury and pulse 75 beats per minute and regular. His blood mass index is 26 kg per square meter. His collar size is 16.5. Investigation, hemoglobin, white blood cells, and platelet within the normal range, potassium, calcium, and creatinine within the normal range. Bicarb is within the normal range. Epworth sleepiness score is 14, which is higher than the normal. Should be lesser than the normal. Which of the following is most likely diagnosis? Functional illness, narcolepsy, obstructive sleep apnea, poor sleep hygiene, temporal lobe epilepsy.
So let me show you. So if can you please mute yourself? Okay, look at here. If a patient comes with the features of fall or collapse following laughter or stress event, then the most likely diagnosis is the cataplexy. And if the cataplexy is associated with the extreme fatigue or excessive daytime sleepiness, and if there is any history of head injury, then the most likely specific diagnosis should be the narcolepsy. So we get back here. So the patient has history of collapse following the stress factors. So this line indicates the cataplexy, and the patient also has the history of head injury, excessive daytime sleepiness with hypnagogic hallucination. So all of them put together, the most likely diagnosis here is the narcolepsy. So the answer should be narcolepsy. And also, why not obstructive sleep apnea syndrome? Because the F4 sleepiness score is normal here. In case of obstructive sleep apnea syndrome, it should be less than 8. Collar size should be greater than 18, and the patient will be obese. So it can be the obstructive sleep apnea. And it can also be the functional illness or poor sleep hygiene or temporal lobe epilepsy. So the most likely diagnosis here is the narcolepsy. So how will you treat this patient with narcolepsy?
Sir, modafinil.
Yes, very good. We'll have to, at first we'll have to give the patient modafinil, and we'll have to undergo the sleep study test. The sleep study test should be done with the polysomnography, and if the polysomnography shows that the patient has the destructive sleep pattern, then you'll have to give the patient CPAP, continuous positive pressure ventilation. So modafinil is the first line treatment, and the modafinil is the default choice of treatment. After that, we'll have to go with the polysomnography. If the polysomnography come out pathological, then we'll also give the patient CPAP. Narcolepsy is likely given excessive daytime sleepiness, collapse suggestive of cataplexy, hypnagogic hallucination with episodes of sleep paralysis. Narcolepsy can be triggered by the head injury. Modafinil is used in patients with the narcolepsy. Next one.
Sorry, I was muted. So sorry. Which of the following is most likely cause of their familial cancer syndrome? BRCA1 mutation, BRCA2 mutation, RAS mutation, RIP mutation, TP53 mutation. A 21-year-old woman presents to the cancer genetic clinic for review. She is very concerned as a number of her first-degree relatives have died from cancer. Identified cancers include breast cancer, leukemia, soft tissue sarcoma, and malignant melanoma. Which of the following is most likely cause of their familial cancer syndrome? BRCA1 or BRCA2 mutation, or RAS, RET, TP53 mutation.
So the breast cancer, leukemia, soft tissue sarcoma, malignant melanoma. This is suggestive of the familial cancer syndrome, also known as the Leigh-Fraumeni syndrome. And Leigh-Fraumeni syndrome is associated with the T53 mutation. If you find the leukemia, breast cancer, soft tissue sarcoma, malignant melanoma, the most likely diagnosis is the Leigh-Fraumeni syndrome. And Leigh-Fraumeni syndrome is associated with the T53 mutation. BRCA1 mutation and BRCA2 mutation is associated with which condition? Can anyone tell me? This is very important for the exam. BRCA1 and BRCA2. Okay, look at here. The BRCA1 is associated with the breast cancer, ovarian cancer, and in case of male, prostate cancer. So breast, ovarian, and prostate cancer. And BRCA2 is associated with all of them consisting the BRCA1, meaning in case of BRCA2 also they will have breast cancer, ovarian cancer, prostate cancer, and plus they will also have the acute myeloid leukemia and pancreatic cancer. So just remember, breast cancer, ovarian cancer in case of male, prostate cancer, all the three suggestive of the BRCA1 mutation. And for BRCA2 we have extra pancreatic cancer, and you'll have the AML. Which one is associated with the RET mutation? Mutation in the T53 gene, which encodes the P53 tumor suppressor protein, leads to an increased risk of range of cancer, including breast cancer, soft tissue, osteosarcoma, leukemia, brain cancer, and adrenal cortical tumors. The mutations occur in a familial cancer syndrome, also known as the Leigh-Fraumeni syndrome, and this is an autosomal dominant condition. And the RET mutation occurs in Hirschsprung's disease and also in case of medullary thyroid cancer, main type 2.
Main type 2 and 3.
Yeah, main type. Is there any main type 3? There is the main type 1, main type 2A, main type 2B. Okay. Okay. Next two.
1 and 2.
Which of the following patients must be given irradiated blood products? A 28-year-old man who has human immunodeficiency virus and is taking highly active antiretroviral therapy. A 48-year-old woman who has received a renal transplant 2 years earlier. A 52-year-old woman who has non-Hodgkin lymphoma. A 62-year-old woman who suffered a transient fever after previous blood transfusion. A 72-year-old woman taking fludarabine for chronic lymphocytic leukemia. You are reviewing guidelines on blood transfusion at the hospital where you work over the past few months. There has been increased use of irradiated red cells. Which of the following patients must be given irradiated blood products? Shall I repeat the options?
No. So they're asking about
Okay.
the indication of giving the irradiated blood products. So in case of CLL, chronic lymphocytic leukemia, one of the treatment is the fludarabine. And this fludarabine is associated with the autoimmune. So in the management of chronic lymphocytic leukemia, one of the drug fludarabine is used, and this fludarabine is associated with the transfusion-associated graft versus host disease (TAGV-ASD). So in order to counter this one, we'll have to give the irradiated blood cell transfusion, and our aim or target should be depletion of the donor WBC. This causes depletion of the donor's WBC, not the recipient. Remember it. This will cause depletion of the donor's WBC. So D for depletion of the donor's WBC, and ultimately the patient will be protected from the transfusion associated graft versus host disease, and for this we'll have to give the irradiated blood cell transfusion. So if we look at the option, the patient is taking fludarabine for his CLL, and this fludarabine is associated with the transfusion associated graft versus host disease, and to counter this we'll have to give the irradiated blood products.
Sorry, irradiated blood products. What does it mean exactly? Irradiated blood products. So, okay.
Actually, I don't know how they actually made the irradiated blood products. Probably this is probably the hematologist. They can tell better regarding this, how to make the irradiated blood products. So fludarabine is associated with the transfusion associated graft versus host disease, and to prevent this, we'll have to give the irradiated blood product.
Okay. Which of the following is the most appropriate next step? Data, glyphosate, glyphosate, add long-acting insulin, add metformin, add dexamethasone, add gliptin. Sorry. 18-year-old man who has hepatic nuclear factor alpha, maturity onset of diabetes of young, presents to the diabetes clinic for review. He is taking glucoside 160 milligrams twice daily for control of his blood sugar. He feels well, although he is a little more tired than usual. His blood pressure is 110 over 80 millimeter mercury and pulse 70 beats per minute and regular. His body mass index is 21 kg per square meter. Hemoglobin, white species, and platelet within the normal range. Platelet, we mentioned this. Sodium, potassium, creatinine, all within the normal. Hemoglobin A1C 63 millimole per mole. Which of the following is most appropriate next step? Add, yeah.
So this is a case of MODI, maturity onset diabetes of the young, and the first line treatment for MODI is the gliclazide, sulfonylurea. And if the patient doesn't respond well to sulfonylurea, we'll have to add the long-acting insulin. So the patient is already given the sulfonylurea here, still the patient is symptomatic or the target level hasn't been raised. So we'll have to add the long-acting insulin. This should be the most appropriate next step. And dapagliflozin is the SGLT2 inhibitor. Can anyone please tell me the mode of action of metformin? What is the mode of action of metformin?
I think inhibitor.
It has many types of action.
4 types.
It acts on AMD.
This is the AMPK. Metformin is
And also it also decreases absorption of carbohydrates from GIT.
okay. Let's see.
Sensitivity.
Metformin causes the decreased hepatic glucose output. This is one of the mechanism. And another one is
Basically, 4. They act on the AMP activated
Yeah.
protein kinase,
they act on
increase
the
the insulin
AMPK.
sensitivity. Yeah. And decrease the hepatic gluconeogenesis.
Sensitivity.
Also reduce the GI absorption of the carbohydrates.
Yes,
4
very good.
mechanisms.
4 mechanisms. The pyroglycation are the PPAR gamma receptor agonist, and gliptins are the DPP4 inhibitors. So you'll have to add the long-acting insulin in case of patient with MOD who doesn't respond to the sulfonylurea. Which of the following correctly reflects the mode of action of cyclophosphamide? Cyclophosphamide has 4 modes of action. So look at here, the cyclophosphamide. The cyclophosphamide causes the DNA alkylation. This is also causes the cross-linking of the DNA. So C for cyclophosphamide, C for cross-linking of DNA, and cross-linking of DNA is also mediated by the cisplatin. And cyclophosphamide causes B cell depletion and T cell modulation. So BD, TM. It is modulating their T cell and causing depletion of the B cell. So don't get confused. BD and MT. So B cell depletion, T cell modulation, cross-linking of the DNA, and DNA alkylation. All of them are the mode of action of cyclophosphamide. And cyclophosphamide is associated with the hemorrhagic cystitis. So cyclophosphamide, this will cause the DNA alkylation. And inhibition of the interleukin-2 production, they are the calcineurin inhibitor. The examples are the cyclosporin and the tacrolimus. Inhibition of the microtubule disassembly, this is mediated by the which drug? Docetaxel. Just remember D for docetaxel, D for disassembly. So this docetaxel causes the disassembly of the microtubule. Thymidylate synthesis inhibition, I don't know. So DNA alkylation, this is mediated by the cyclophosphamide. This causes the hemorrhagic cystitis. Which one is CTLA4 protein receptor inhibition? So interleukin-2 are the cyclosporin and tacrolimus. Docetaxel causes disruption or disassembly of the microtubule. And this example here of the thymidylate synthesis inhibition is the fluorouracil. Yeah, fluorouracil. Okay, next one.
Which of the following daily morphine doses approximates the phase 2 hair current codeine description? 10 or 20 or 30 or 40 or 60 milligram. A 62-year-old woman comes to the palliative care clinic for review. She has metastatic breast cancer with polymetastasis and is currently managed with codamol 3/500, 2 tablets 4 times a day, and ibuprofen 400 milligrams 3 times a day. You plan to transfer her to oral morphine to further titrate her pain relief, and her pain is not currently adequately controlled. Which of the following daily morphine dose approximate the best to her current codeine prescription, 10, 20, 30, 40, 50 milligram.
So they are asking about the conversion ratio from the oral codeine to the daily oral morphine. So the patient is getting cocodamol 30 by 500, 2 tablets. So 30 into 2 into 4. So 60 into 4 is equal to 240 milligram. So the patient is getting 240 milligram of codeine tablet per 24 hours. As her pain isn't currently adequately controlled. So according to the NICE guideline, after giving a certain dose of opioid analgesic, if the pain is uncontrolled, then the next dose should be increased by 30 to 50%. So if we increase the 50%, then the dose should be 240 plus 120. How much? 240 plus 120?
360.
Yeah, 360. And we know that the conversion ratio from oral codeine to oral morphine, we'll have to divide the oral codeine dose by 10. So 360 divided by 10 is equal to 36. And 40 milligram is more closer, so we'll have to 40 milligram should be now. So 40 milligram.
Which of the following is the most appropriate next step? Amlodipine, prednisolone, ramipril, reassurance, spironolactone. An 18-year-old man comes to renal clinic for review. He has recently been diagnosed with Alport syndrome. His elder brother also has the condition and has chronic kidney disease, stage 3B. The patient has a blood pressure of 135 over 80 mmHg, and his pulse is 70 beats per minute and regular. His body mass index is 22 kg per square meter. Investigation: hemoglobin, white disease, and platelet normal. Hemoglobin within the lower range of normal. Sodium, potassium, and creatinine all normal. 24 urinary protein 1.8 gram, which is higher than the normal, which should be less than 0.15 gram. Which of the following is most appropriate next step? Amlodipine, prednisolone, ramipril, reassurance, spironolactone. Is it prednisolone?
Okay, so the Alport syndrome, if a patient with Alport syndrome comes up with the features of proteinuria for the reduction of the proteinuria, we'll have to either give the AC inhibitor or ARBs as the first line drug, and the second line drug should be the aldosterone antagonist. So the patient here has the Alport syndrome, has come up with the proteinuria. So the first line treatment should be either AC inhibitor or the angiotensin receptor blocker. So the most appropriate next step here should be the ramipril. And if the patient doesn't respond well to ramipril, then for second step we can add the aldosterone antagonist, that is either spironolactone or the eplerenone. Can anyone tell me the mode of inheritance of Alport syndrome?
Dominant one.
X-linked.
Autosomal dominant.
Not autosomal
It
dominant.
is
Alport syndrome in most of the cases follows the X-linked dominant pattern. In negligible cases, it can follow the X-linked recessive. But for example, you can remember this follows the X-linked dominant pattern, XLD. AC inhibitor or ARBs, they are the intervention of choice to reduce proteinuria and slow the renal progression in a patient with Alport syndrome. And this follows the X-linked dominant pattern in most of the cases. And this spironolactone or eplerenone, this should be the second line of treatment.
Yeah. Which of the following would you expect to find on pleural fluid testing? Blood staining, pH 7.1, pleural fluid glucose 4.5 millimolar per liter, pleural fluid lactate dehydrogenase to serum LDH 0.4, pleural fluid protein to serum protein 0.3. A 64-year-old woman who has rheumatoid arthritis managed with methotrexate comes to the clinic complaining of shortness of breath and dull left-sided chest aches and pains over the last few months. Examination reveals a blood pressure of 147 over 85 millimeter mercury and a pulse of 74 beats per minute and regular. Percussion is dull at the left base, and there are decreased spirit sounds on auscultation. X-ray reveals a pulmonary nodules and a left pleural effusion. You believe the effusion is related to her rheumatoid arthritis. Which of the following would you expect to find on pleural fluid testing? Blood staining, pH 7.1, pleural fluid glucose 4.5, or pleural fluid lactate LDH to serum LDH is 0.4, pleural fluid protein to serum protein 0.3.
So the rheumatoid arthritis or the unilateral pleural effusion, this is mostly associated with the exudative transfusion, and in case of exudative transfusion, the pH level should be less than 7.2. So pH 7.1, this indicates the exudative effusion, and this occurs in case of rheumatoid arthritis. Blood staining can occur in case of traumatic aspiration or malignant effusion. And in case of exudative transfusion, the pleural fluid glucose level will be very low, near 1 or 1.5. And the pleural fluid lactate LDH, serum LDH 0.4, and the pleural fluid protein and serum protein 4. These are suggestive of the transudative effusion, like in case of either cirrhosis or cardiac failure. So the pH level less than 7.2, this points towards the exudative transfusion. A pH lower than 7.2 is a strong pointer towards pleural effusion related to rheumatoid arthritis. Causes of the pleural effusion of below 7.3 indicates rheumatoid arthritis, connective tissue disorder, malignancy, empyema, tuberculous pleural effusion, esophageal rupture. The low pH occurs because of locally increased metabolic activity and buildup of the lactic acid. And blood staining can occur in traumatic aspiration or malignant effusion. And the exudative will have very low pleural fluid glucose level. It should be less than 1.6 millimole per liter. And the ratio 0.4, ratio 0.3, these two are suggestive of transudative effusion.
Which of the following is most likely cause of this patient's speech? Cardiac arrhythmia, hypertrophic obstructive cardiomyopathy, neural mediated syncope, orthostatic hypotension, subclinical.
We can't hear you.
29-year-old woman. Sorry?
We can't hear you properly. Okay, please continue.
A 29-year-old woman is reviewed in the emergency department, having suffered a syncopal episode after standing still for prolonged period at reception. She has no significant medical illness and takes no regular medication. Her blood pressure is 118 over 78, and her pulse is 67 beats per minute and regular. Her body mass index is 23 kg per square meter. Which of the following is most likely cause of this patient's faint? Cardiac arrhythmia, hypertrophic obstructive cardiomyopathy, neurally mediated syncope, orthostatic hypotension, subclinical syndrome.
So this is a young patient has come in with the features of syncopal episode after standing still for a prolonged period at the reception, and there is no significant medical illness, and everything else is normal. So most probably this is a case of vasovagal syncope, or the vasovagal syncope falls under the headline of the neurally mediated syncope. So neurally mediated syncope or the vasovagal syncope has been the most likely cause of the patient fainting in this case, and you'll have to just reassure the patient. Neurally mediated syncope is the most likely diagnosis here in a young patient with no significant medical illnesses. Vasovagal syncope, the most likely cause here, can have an emotional trigger or be related to the orthostatic stress. And in the scenario, the orthostatic stress has been the underlying pathophysiology. Other causes of neurally mediated syncope includes the micturition syncope and syncope precipitated by the gastrointestinal stimulation. Carotid sinus hypersensitivity is also classified as neurally mediated syncope and occurs when rotating the head. So there is a long list of example of the neurally mediated syncope, and all of the cases the patient will have just the transient loss of consciousness or fainting, and everything else will be normal, and the patient will have the no significant medical illnesses, and the treatment should be reassurance. Which of the following is the mode of action of aspirin? Aspirin is the NSI, so this causes the COX-1 and COX-2 inhibition. Selective COX-2 inhibition is mediated by the coxibs like celecoxib, rofecoxib, valdecoxib, or ichorocoxib. P2Y12 receptor inhibition, this is mediated, we just discussed yesterday. This is the example of the clopidogrel, ticagrelor, ciclopidine, and this is mediated by the ADP receptor property. And glycoprotein 2B3A inhibition, they are the tyrofibin, eptafabetide, and the abciximab, and they are used for the patient who are going for the cath lab, coronary angiography. So aspirin is the non-selective COX-1 COX-2 inhibition. Abciximab, tyrofibin, and eptafabetide, they are the glycoprotein 2B3A inhibitors. P2Y12 inhibitors mediated by the ADP, they are the clopidogrel, ticagrelor, prasugrel. There is nothing called selective COX-1 inhibitors. Selective COX-2 are the coxibs, all the coxibs, and all the coxibs have the gastroprotective function, but they are not cardioprotective. So this type of selective COX-2 inhibitor can't be used in a patient who has the cardiac disease or in case of older patient. Which of the following marks out audit versus clinical research? Okay, read the options.
A clinically relevant endpoint measures, cost-benefit analysis, re-audit against standards, statistical testing, time between initial data cut and re-analysis. As part of training portfolio, you are required to complete an audit, which the following marks out audit versus clinical research.
So what should be the answer here for marking out audit versus clinical research? We have to go for the re-audit. The re-audit against standard. This is the key principle. This is the key principle to look whether the clinical trial is successful or not. So re-audit against standard, closing the loop or re-audit against standard is the key principle of a successful audit. Without it, the process is not complete. Where process improvement is put in place, the standard may be progressively tightened with repetitive audit cycles. The time of the audit cycle depends on the outcome being assessed. So re-audit against standard, this is the key principle to determine whether the clinical trial or the clinical research is successful or not.
Which of the following is most appropriate treatment for hair glucose control? Basal bolus insulin, lipineclamide, lifestyle only, lifestyle metformin and basal bolus insulin, sitagliptin. Sitagliptin. A 26-year-old woman who is 18 weeks pregnant with her first child is referred to the diabetes clinic after being found to have glycosuria at the GB antenatal clinic. She has no previous medical illness, although she is obese and smokes 5 cigarettes per day. Her blood pressure is 132 over 84 millimeter mercury, and her pulse is 70 beats per minute and regular. Her body mass index is 31 kg per square meter. Investigation: hemoglobin, white pieces, and platelet all normal. Sodium, potassium, creatinine all normal. Fasting blood glucose is high, 10.3 millimolar per liter. Which of the following is most appropriate treatment for hair glucose control? We mentioned basal bolus insulin, glibenclamide, lifestyle, only lifestyle metformin, basal bolus insulin, sitagliptin.
So what should be the answer here? Pregnant lady coming up with the fasting blood sugar with 10.3.
So lifestyle, metformin, and basal bolus insulin, all three.
Basal
Yes,
bolus insulin.
very
Big. Yeah.
So if a pregnant lady comes and the fasting plasma glucose level is greater than 7 millimole per liter, then you will have to offer the pregnant lady the insulin. And this insulin should be given in combination with the lifestyle modification and also with the metformin. And since the patient BMI is high here, 31 kg per meter square, so it will be more logical to add metformin along with the insulin. So the most likely answer here should be the lifestyle modification plus metformin plus the basal bolus insulin regimen. In this situation, with the fasting plasma glucose above 7 millimole per liter, starting insulin is the only practical option to reduce the risk of diabetes-related pregnancy complication. A basal bolus regime or insulin pump therapy, if the patient can manage it, are appropriate regimen. These should be coupled with both metformin and lifestyle intervention to minimize the maternal weight gain.
Which of the following is most appropriate intervention for hair incontinence? Doxazine, lecithin, finasteride, mirabegron, and the last one, oxybutynin. A 72-year-old woman comes to the clinic for review with respect to symptoms of stress incontinence, despite complaints with pelvic floor exercise and having lost 4 kg in weight. She's still incontinent of urine on 2 to 3 occasions over the course of her of the day. When she laughs, moves around the house, or strains to get out of a chair, which of the following is most appropriate intervention for hair incontinence? Doxazine, duloxetine, finasteride, mirabegron, oxybutynin.
So old lady coming up with the features of stress incontinence, and the first line treatment for stress incontinence is the pelvic floor exercise. And if the patient doesn't respond well to pelvic floor exercise, we have to go with the drug therapy. And just remember, the stress causes the distress, and stress incontinence, this is treated with the duloxetine. So duloxetine is the drug of choice in case of stress incontinence. And doxazosin and finasteride, these two drugs are used in the management of benign prostatic hyperplasia. Doxazosin is the alpha-1 receptor blocker, and this will causes the relaxation of the prostatic muscle. and finasteride is the 5A alpha reductase inhibitor, and this finasteride will causes reduction in the volume of the prostate. So often these two drugs, finasteride and doxazosin, is given in combination in a patient with benign prostatic hyperplasia. The mirabegron is the beta 3 receptor agonist, and this is used in the management of urge incontinence in the elderly patient. This mirabegron is on the first line treatment. This is the third line treatment. This is reserved for the elderly patient. But if the patient have some sort of psychotic problems, then mirabegron should be used. The first line treatment for urge incontinence is the larger retaining training, and the second line is the anticholinergic drugs like either oxybutynin or cholchiratin. And if the patient is elderly or some sort of psychotic problem, then we can either give the mirabegron. So for stress incontinence, the first line treatment is the pelvic floor exercise, and the drug treatment is the duloxetine. And for urge incontinence, we can go with the anticholinergic drugs like oxybutynin or cholchiratin. And for elderly patient, we can give the mirabegron. Can anyone tell me the mode of action of duloxetine? What is
So
the
it's
mode?
serotonin reuptake inhibitor, I think, sir.
Yes, I just simply remembered the duloxetine as the SN-orin. So serotonin noradrenaline reuptake inhibitor. So
Okay, sir. All right.
SNARIN, okay. Serotonin noradrenaline reuptake inhibitor. This is the mode of action of duloxetine, and stress will cause the distress. So treatment is with the duloxetine. Doxazosin is the alpha receptor blocker. This is used in the management of benign prostatic hypertrophy, and this is also used in the fifth line or the last line of treatment in case of hypertension. Finasteride is also used in the treatment of BPH. Mirabegron is the beta 3 receptor agonist, and this is used in the treatment of urge incontinence in the elderly patient. And oxybutynin is the first line choice of drug in case of urge incontinence. This is the anticholinergic drug. Can anyone else read?
Yes.
Anyone else?
I can read.
Okay, please.
So may I
Shall
continue?
Yeah.
Okay, continue. Anyone?
So may I?
Yes, please continue.
Which of the following is the most important contributor
Which
to
of the
risk
following is the most important?
Okay, you read. Okay, you read.
Go on, read.
Okay, thank you. Which of the following is the most important contributor to risk of future stroke? Blood pressure 152 by 92 millimeter of mercury, creatinine level 132 millimole per liter, diagnosis type 2 diabetes, duration of expressive dysphagia of 80 minutes, presence of expressive dysphagia. A 67-year-old man is admitted to the emergency department with expressive dysphagia. He has type 2 diabetes and hypertension and smokes 5 cigarettes per day. His blood pressure is 152 by 92 millimeter of mercury and his pulse is 80 beats per minute and regular. His body mass index is 28 kg per meter square. By the time you see him, his expressive dysphagia has completely resolved 18 minutes after onset. Investigations: hemoglobin 14.1, WBC 9, platelet 161,
Sodium 144, potassium 4.7, creatinine 132, creatinine slightly raised. And CT head, no sign of intracranial hemorrhage, no evidence of previous cerebral infarcts. Which of the following is the most important contributor to risk of future stroke?
So this is a case of ischemic stroke, and they are asking which of the following is the most important contributor to the risk of his future stroke. So we have to go with the ABCD2 criteria or ABCD2 assessment. And in the parameter, if there is unilateral weakness or if the duration is greater or equal to 60 minutes, this indicates 2 point and this carries the worst prognosis. So there is no unilateral weakness here, but the duration here is greater than 60 minutes. So duration of expressive dysphagia of 80 minutes, this carries the highest risk of future stroke. So just look at here, the event which are associated with the highest risk of future stroke according to the ABCD2 score are prolonged duration of symptoms and both limb weakness, speech disturbance, which together adds 2 plus to the score. So 2 points, this is indicated by either unilateral weakness and the duration should be greater or equal to 60 minutes. So if the duration is greater or equal to 60 minutes, this carries 2 point and 2 point means the increased risk of future stroke. So if the score is 1 to 3, carries 1% 2-day stroke risk. If the score is 4 to 5, this will carry 4.1%. And if the score is 6 or 7, this will carry the 8% to the stroke risk. So just remember, if the duration is greater or equal to 60 minutes.
Okay. Which of the following is the most appropriate initial way to manage his renal dysfunction? 0.9% saline, calcium gluconate, furosemide, mannitol, sodium bicarbonate. Which of the A 73-year-old man is brought to the emergency department by ambulance, having been found on the floor by his home help. He has been unwell for the past few days with a respiratory tract infection, and he apparently fell but was unable to get up. He has multiple comorbidities, including hypertension and ischemic heart disease. He is pyrical with a temperature of 38.8 degrees Celsius, blood pressure of 105 by 82 millimeter of mercury, and pulse of 98 beats per minute and regular. There are crackles at the left base on auscultation of the chest. Investigations: hemoglobin 13.1, WBC 15.7, platelet 303, all are normal. Sodium 142, potassium 5.6 raised, creatinine 156 raised, bicarbonate 18, creatinine kinase 2436 unit per liter, and urine blood positive on dipstick, but no red cells seen on microscopy. Chest X-ray consolidate at left base. Which is the most appropriate initial way to manage his renal dysfunction?
So the patient was found on the floor by his home help, and the patient also have the significantly elevated creatinine kinase. So most likely this is a case of rhabdomyolysis and the renal impairment. The renal impairment can be explained using the rhabdomyolysis, because in case of rhabdomyolysis, the myoglobin will tends to get excreted through the kidney, and this myoglobin will cause the renal vasoconstriction, and that renal vasoconstriction will cause a significant elevation of the creatinine, elevation of potassium level, giving rise to the renal impairment. So significantly elevated creatinine kinase along with the renal impairment with the metabolic acidosis and also with the history of the found on the floor by his home help, the most likely diagnosis here is the rhabdomyolysis, and we'll have to treat this patient by giving the IV normal saline. So 0.9%.
0.9% sodium saline.
So 0.9% saline should be the most appropriate initial step of this management. And after that, we can either go with the hemodialysis depending on the situation of the patient. This patient has rhabdomyolysis as a result of spending a considerable period of time on the floor. This has resulted in elevation of the creatinine kinase level, renal failure with the mild acidosis, and blood on urine dipstick, which is on confront on the microscopy. And also see here, the blood positive here doesn't indicate hematuria. This is due to the myoglobinuria. Myoglobin is thought to cause renal vasoconstriction, can drive to the formation of the intratubular cast. And to remove this intratubular cast, we have to give the IV hydration with the normal saline. And this IV hydration with the normal saline, this will cause reduction in the accumulation of the myoglobin in the kidney tubule. So this should be the initial stage of management. Yes, next one.
Okay. Which of the following is the most likely cause of his symptoms? Bronchial carcinoid, bronchial carcinoma, lymphoma, sarcoidosis, or TB, tuberculosis? A 24-year-old man who has moved to the United Kingdom from Russia is referred to the respiratory clinic. He has had a chronic cough and night sweats and has lost 5 kg in weight over the past 3 months. He smokes 20 cigarettes per day and drinks 10 units of alcohol per week. He has not received the BCG vaccination. His blood pressure is 123 per 82 millimeter of mercury and his pulse is 82 beats per minute and regular. You note some cervical lymphadenopathy. Investigation: hemoglobin, WBC platelet all are normal, sodium 142, potassium 4.5, creatinine 102. CRP 82, which is raised. Chest X-ray shows patchy right or upper zone fibrosis. MT test positive. The diagnosis may be tuberculosis.
So this patient is having the features of fibrosis of the chest X-ray. Monto test is positive, and the patient has also the classical features of chronic cough, night sweat, significant weight loss with a smoking history, and not receiving the BCG vaccine, with features of cervical lymph node involvement and signs of consolidation. So everything can be explained by using the tuberculosis. And the sarcoidosis, this usually occurs in case of Afro-Caribbean patient. In this case, the MT test will be negative, and the patient will have the bilateral hilar lymphadenopathy. Fibrosis is uncommon in case of sarcoidosis. Lymphoma won't have the Monto test positivity, and also the bronchial carcinoid. Bronchial carcinoid will come up with the cherry red lesion. The patient will have the history of recurrent hemoptysis, and this occurs in the younger patient. And the bronchial carcinoma, this occurs in the older age group patient. And depending on the situation, in case of squamous cell carcinoma, there will be hypercalcemia, and in case of small cell cancer, there will be either hyponatremia or this will be associated with the Cushing syndrome. All of them are absent here. So the most likely diagnosis here is the tuberculosis, and we will have to treat the patient by giving the anti-TB drugs. 4 FDC for first 2 months, followed by 2 FDC following the next 4 months. The presence of weight loss, night sweats, upper lobe consolidation, and lymphadenopathy in the presence of positive Monto test is consistent with the pulmonary tuberculosis until proven otherwise. At least 3 samples of sputum for microscopy and culture should be sent. Nucleic acid amplification testing should be considered for Mycobacterium tuberculosis. The standard anti-tuberculosis regimen for pulmonary tuberculosis is isoniazid with pyridoxine, rifampicin, pyrazinamide, ethambutol, meaning 4 FDC for 2 months and 2 FDC for 4 months.
Here it is mentioned as fibrosis, right? Upper zone fibrosis. No?
Yeah, this is a aperture, patchy right aperture fibrosis. Yes.
Fibrosis will have this sort of clinical presentation.
Which type of presentation? Are you saying chronic cough, night sweat, this type of
Yeah.
presentation? No, no, no. The chronic cough, night sweat, these are the presentation of the tuberculosis. The fibrosis might have some sort of breathlessness, and in case of fibrosis, the patient will have the low breath sound, and the auscultation sound will be low here, and there will be drooping of the shoulder in case of fibrosis. The commonest cause of the fibrosis in the Indian subcontinent is the tuberculosis. Tuberculosis is the most common cause of fibrosis in case of Indian subcontinent. Okay, next one.
Which of the following is the most appropriate intervention? Anterior temporal lobectomy, add phenobarbital, add pregabalin, add topiramate, deep brain stimulation. A 43-year-old man is referred to the specialist epilepsy clinic for review. He has temporal lobe epilepsy, which is not controlled despite dual therapy with levetiracetam and oxcarbazine. He suffers up to 5 seizures per day and is currently unable to work. A magnetic MRI brain shows right-sided changes with hippocampal atrophy, increased T2 signal affecting the right temporal lobe, and loss of the normal interdigitations of the hippocampus. The temporal horn of the lateral ventricle is enlarged on the right. Uh, Most appropriate intervention.
So this patient has the temporal lobe epilepsy, and the patient is being treated with the dual therapy with two anti-epileptic drug, levetiracetam and oxcarbazepine. But still the patient has the features of seizure. So this is the case of resistant temporal lobe epilepsy, and the resistant temporal lobe epilepsy plus MRI finding showing the changes in the hippocampal atrophy with increased T2 signal, with the enlarged lateral ventricle and interdigitation. All of them is suggestive of the MTS. MTS means mesial temporal sclerosis. So resistant temporal lobe epilepsy plus the MRI findings suggestive of hippocampal atrophy, increased T2 signal, interdigitation and enlargement of the lateral ventricle. The diagnosis is the MTS, mesial temporal sclerosis, and mesial temporal sclerosis should be treated surgically, and the treatment should be anterior temporal lobectomy. This is the treatment for MTS. Anterior temporal lobectomy. This patient's symptoms and MRI appearance are consistent with mesial temporal sclerosis. In short, this is known as the MTS. Okay, here is the MTS. In patients who have trialed at least 2 anti-epileptic seizure and still have the disabling seizure, as mentioned here, anterior temporal lobectomy results in a higher seizure-free rate compared to continuing anti-epileptic medication and a much better quality of the life. And you will have to memorize the MRI findings of the MTS. There will be changes in the hippocampal atrophy, increased T2 signal. There will be interdigitation and enlargement of the lateral ventricle. All of them occurs in case of MTS. And treatment is surgically lobectomy.
Which of the following is the most likely site of arterial occlusion? Anterior cerebral artery, lenticulostriate arteries, middle cerebral artery, posterior cerebral artery, vertebral artery. A 64-year-old man who has diabetes mellitus and hypertension present to the emergency department with sudden onset right-sided weakness. The weakness predominantly affects the right side of his face and his right arm, and sensation is diminished on the right hand side. He has expressive dysphagia and is persistently looking to the left hand side. Expressive middle cerebral artery.
So this patient is having the features of expressive dysphagia with hemisensory loss and also the ipsilateral weakness. So if a patient comes up with the features of stroke or the ipsilateral weakness, then in order to differentiate between the MCA and the anterior cerebral artery, we have to look whether the upper limb is more involved or the lower limb. If the face and upper limb is more involved compared to the lower limb, then the site of lesion is in the MCA. So in case of MCA, the face and the upper limb will be more affected. And in case of anterior cerebral artery, the lower limb will be more affected compared to the upper limb. So if we see here, so weakness predominantly affects the right side of his face and his right arm. So this is affecting the upper surface more. So the most likely site of lesion should be the middle cerebral artery. The symptoms seen here fits with the diagnosis of the MCA stroke. There has been background noise. Okay, yes, now it. The symptoms seen here fits well with the diagnosis of the MCA stroke. MCA occlusion commonly produce the following: contralateral hemiparesis, contralateral sensory loss, ipsilateral hemianopsia, gaze preference towards the side of the lesion, agnosia, receptive or expressive aphasia, with the dominant hemisphere lesion. Weakness of the face and upper limb is usually more marked than the lower limb in case of medial cerebral artery, and in case of anterior cerebral artery, lower limb will be more prominent compared to the upper limb. So upper limb greater than lower limb is equal to MCA. Lower limb greater than upper limb is equal to ACA. Which of the following is the sensitivity of the new test? So calculate the sensitivity here. True positive divided by true positive. So this is the true positive divided by true positive plus false negative. So 47 divided by 47 plus 3. This is the sensitivity. 97 divided by 99. This is the specificity. 47 divided by 49. This is the positive predictive value. 97 divided by 100. This is the negative predictive value. So if we go in this direction from up to low, this is the sensitivity. And from down to up, this is the specificity. From right to left, this is the positive predictive value, and from left to right, this is the negative predictive value. So 47 divided by 50, it should be
94.
Yes, it should be 90.
Which of the following is the biggest pointer towards obesity hypoventilation syndrome? Body mass index 37 kg per meter square, hemoglobin 14 gram per deciliter, nocturnal snoring, serum bicarbonate 32 millimole per liter, systolic BP 148 millimeter of mercury. A 44-year-old man comes to the clinic for evaluation of his breathing. He is feeling increasingly tired and according to his wife, he snores every night. He has asthma diagnosed by general practitioner, but he is otherwise well. His blood pressure is 148 by 85 millimeter of mercury and his pulse is 78 beats per meter and regular. His chest is clear. His abdomen is soft and non-tender, and he is obese with a body mass index of 37 kg per meter square. Investigation: hemoglobin 14, WBC 7.2, platelets 382, sodium 140, potassium 4.5, creatinine 110. All are normal. Bicarbonate 32 millimole per liter, slightly raised. Biggest pointer towards obesity hypoventilation syndrome.
So this patient is having the features of snoring. The patient is obese and along with the high BMI. And the patient also has the elevated bicarbonate level, and this indicates the metabolic alkalosis. And elevated bicarbonate level or metabolic alkalosis also indicates the chronic carbon dioxide retention. And there has been some sort of renal compensation here. And this elevated bicarbonate level, this is the biggest pointer towards the obesity hypoventilation syndrome. Because if the bicarbonate level is less than 26 or 27, then the obesity hypoventilation syndrome is partially excluded. So high bicarbonate level, this is the biggest pointer towards the obesity hypoventilation syndrome. So how will we manage this patient? Management of this patient?
CPAP. Using CPAP.
Not directly using CPAP. The, the, the,
No,
the,
first of all,
the
lifestyle
the first line intervention should be the lifestyle modification with the weight reduction. And after that, we can go with the sleep study. We can go with the polysomnography, and if polysomnography comes out positive, then only in that case you will need the CPAP. Otherwise, the weight reduction or lifestyle modification would be enough for this patient. An elevated serum bicarbonate is consistent with the chronic carbon dioxide retention and renal compensation and is a strong pointer towards underlying obesity hypoventilation syndrome. A serum bicarbonate level less than 27 has a 97% negative predictive value for obesity hypoventilation syndrome. So this line means if the bicarbonate level is less than 27 millimole per liter, then the obesity hypoventilation syndrome is least likely and is therefore an ideal initial investigation before moving on to the arterial blood gas measurement. An overnight sleep study is the optimal way to confirm the diagnosis with continuous positive airway pressure coupled with weight loss as the optimal intervention. So weight loss should be the mainstay of treatment. After that, we will go with the polysomnography. If the test comes out any pathology, then we can go with the CPAP, continuous positive airway pressure. Which of the following is the mode of action of the timolol? Timolol is the beta blocker, right? So what's the mode of action of timolol in ophthalmological condition?
we couldn't hear you.
Which of the following is the mode of action of timolol? It causes the
Sorry,
reduced
reduced
formation of the
Aqueous
aqueous
humor.
humor. Yes. Carbonic anhydrous inhibition is mediated by the acetazolamide. Then arterial constriction of the conjunctiva. This is mediated by the alpha receptor blockers like the phenylephrine. Beta blockers such as timolol leads to the reduction of the intraocular pressure by reducing the production of the aqueous humor. So decreased aqueous humor production, this is the mode of action of the beta blockers in ophthalmology. Phenylephrine, this acts on the alpha adrenergic receptor. Acetazolamide is the carbonic anhydrous inhibitor. Pilocarpine. Pilocarpine is the muscarinic receptor antagonist. No. Pilocarpine is the muscarinic receptor agonist, right?
Agonist.
Yes.
Yeah, yeah.
Pilocarpine is the muscarinic receptor agonist, and atropine is the muscarinic receptor antagonist. So there has been a slight printing mistake here. So pilocarpine is the muscarinic receptor agonist and atropine is the muscarinic receptor antagonist. Where is the beta-2 adrenergic receptor located? The beta-2 adrenergic receptor, this is the class, this falls under the GPCR, G protein coupled receptor. There is a long list of G protein coupled receptor. One of the example is the beta-2 adrenergic receptor, and the location is in the cell membrane or in the plasma membrane. And the thyroid hormone receptor is located in the nucleus. So beta-2 adrenergic receptor, this is a subclass of the GPCR, G protein coupled receptor, and the location is in the cell membrane or the plasma membrane. Adrenergic receptor, including the beta-2 receptor, are a class of transmembrane G protein coupled receptor. The receptor is located to the GSG protein, which activates the adenylyl synthase. Yes, you have the thyroid hormone. Okay, let's do.
Which of the following is the most appropriate intervention for orchitis in this patient? Acyclovir, flucloxacillin, ganciclovir, ibuprofen, ofloxacin. A 20-year-old student comes to the emergency department with swollen, painful testes. He had developed fever and parotitis with severe headache and was thought to have mumps, according to the general practitioner at the Student Health Service. He has never received a vaccination for mumps. His temperature is 38.9 degrees Celsius, BP 105 by 80 millimeter of mercury, and pulse 96 beats per minute and regular. He has bilateral parotitis and orchitis. Investigations: hemoglobin 13.7, WBC 8.2, platelet 301, sodium 144, potassium 4.5, creatinine 118, bicarbonate 25, CRP 71, slightly raised, and anti-mumps immunoglobulin IgM positive. Most appropriate intervention for orchitis.
So this is a case of mumps orchitis, and mumps orchitis is always treated conservatively, and you'll have to give the symptomatic management. Just give the antipyretics along with the NSAIDs. So ibuprofen and paracetamol should be the treatment of choice for mumps orchitis. Supportive therapy is the intervention of choice for mumps infection. Paracetamol is used as an antipyretic, and a non-steroid NSAID such as ibuprofen used in combination with the paracetamol are particularly effective in combating pain related to the orchitis. And the ganciclovir or the valganciclovir, they are used in the treatment of cytomegalovirus infection. Next one, and this should be the last question of our today's session. Okay, read.
Which of the following is the most likely diagnosis? Branch retinal artery occlusion, branch retinal vein occlusion, central retinal artery occlusion, central retinal vein occlusion, optic atrophy.
Read the scenario.
A 62-year-old man who has hypertension and atrial fibrillation comes to the emergency department complaining of blurred vision affecting his left eye when he looks down. He says he woke up with the blurred vision and he has no pain from the eye. His BP is 145 by 90 millimeter of mercury and his pulse is 90 beats per minute in atrial fibrillation. Retinal photography reveals pallor and paucity of blood vessels over the upper half of the left retina. Most likely diagnosis.
Branch retinal.
Yes, very good. This is the case of transretinal vein or artery.
Artery occlusion.
Okay, look at here. One is the central retinal vein occlusion, another one is the central retinal artery occlusion. Both of them will come with the painless loss of vision. Both central retinal vein occlusion and central retinal artery occlusion, both of them will come up with the painless loss of vision. And to differentiate, in case of retinal vein occlusion, there will be flame-shaped hemorrhage. And in case of central retinal artery occlusion, there will be pale retina and there will be cherry red spot. So painless loss of vision plus flame-shaped hemorrhage. The diagnosis is the central retinal vein occlusion or CRVO. And painless loss of vision plus pale retina with or without cherry red spot. This indicates the central retinal artery occlusion. And if we look at the parameter here, the retinal photography reveals pallor. So this indicates pale retina and the paucity of the blood vessel over the upper half of the left retina. So only the upper quadrant of the retina is being affected here. And in case of central lesion, the entire quadrant will be affected. So for central retinal artery occlusion and for central retinal vein occlusion, the entire quadrant will be affected. But here only the upper quadrant has been affected. So it will be branch occlusion. So now we'll have to look whether this is arterial occlusion or vein occlusion. And we say in case of vein occlusion, there will be flame-shaped hemorrhage. In case of arterial occlusion, there will be pale retina and cherry red spot. So here is the pale retina. So the most likely diagnosis here is the branch retinal artery occlusion. And optic atrophy has a long list of causes, and one of the most common cause of optic atrophy is the multiple sclerosis. And optic atrophy is associated with the optic disc pallor. There will be pale optic disc, and there will be loss of the central vision. So what should be the treatment for branch retinal artery occlusion? Treatment of branch retinal artery occlusion or central retinal artery occlusion? Anyone treatment?
Sir, laser photocoagulation.
No, not laser photocoagulation. Central retinal artery occlusion or branch retinal artery occlusion, they should be treated with the intra-arterial thrombolysis. And intra-arterial thrombolysis can be done with the anti-VEGF, meaning the antivascular endothelial growth factor, and the example are the bevacizumab. So branch retinal artery occlusion, lower half of the visual field, retinal pallor over the upper portion of the retina in a patient with atrial fibrillation is consistent with the branch retinal artery occlusion due to embolus, and the treatment should be anti-VEGF, bevacizumab or rancizumab. And branch retinal artery will have flame-shaped hemorrhage, and only one of the quadrant will be affected. Central retinal artery entire quadrant will be affected with pale retina with shaded spot. Then flame-shaped hemorrhage. You can also get that dot and blot hemorrhage. And optic atrophy, commonest cause of optic atrophy is the multiple sclerosis, and this is associated with the loss of central vision and pale optic disc. So thank you everyone. I think we can conclude here today. Inshallah, we'll continue from tomorrow.
Thank you, sir.
Thank you.
Sir, tomorrow is
Thank you.
for tomorrow.
Tomorrow will be at 2:30 p.m. in the GMT mean time. Okay, 2:30 p.m. during the regular timing, not 30-minute delay. We'll continue at the 2:30 p.m. Okay, thank you.
Thank you, sir.
Thank you.